Hello, and welcome to week 13 for the clinical nurse specialist students or student. This is Dr. Becker again. What we're going to do this week is touch a little bit about what the role is and a little bit about, again, your competencies and your spheres of influence, some of the current concerns, how the role can be implemented, future directions, and some of those things. I did discuss this with Dr. Lynn White, and she felt that these slides were appropriate. So also, though, take it with a grain of salt that I am not a clinical nurse specialist. So these things that I am sharing with you, if you should see something that is like, you're like, maybe not so much, please discuss that with Dr. White. Again, I'm taking this from Hamrick and Hansen's Advanced Practice Nursing, the 7th edition. Which is an excellent resource, and I would recommend considering to have that, especially as a CNS student. All right, so as a CNS, the reasons the role was created was to provide direct care to patients with complex diseases or conditions. It also allowed for improved outcomes for these populations, and especially within specialist arenas like oncology or critical care. Advanced clinical expertise in the specialty population could be very helpful, they found, and that's in essence at the core of the CNS role. I like how they talked about in the reading, historically the role has been versatile, evolving, flexing, responding, and adapting to patient populations and healthcare environments. However, the core strength of the CNS is providing complex specialty care while improving the quality of care delivered, and that has remained central to the understanding of this APRN role, which I really, I like how they worded that in that. You're going to improve patient care by developing clinical skills and judgment of staff nurses and retain nurses who are experts in clinical practice. In the statement on clinical nurse specialist practice and education, the NACNS in 2019 defined the CNS as an APRN who directly and indirectly manages the care of the complex and vulnerable patients and families, populations, and communities, also educates, mentors, and supports nursing and nursing staff, and provides the clinical expertise to facilitate change and innovation in healthcare organizations. I like that definition, and as you proceed into your next stage with Dr. White, you're going to explore these in even more and more detail. But I did want to point out that that specifically includes the idea of direct and indirect care, which we spoke about a few weeks ago in one of my lectures. And that still is very much what the CNS role is. And I would argue that a lot of the indirect care is done by the CNS, even though you're still within the direct clinical practice. And again, I already kind of read through those there. So as a clinical nurse specialist, your competencies that they really focus on within the CNS realm is the direct care, consultation, systems leadership, collaboration, coaching, research, and ethical decision making. And I do point that out because I do feel that the nurse practitioner role tends to be more into clinical leadership, and I do see that the CNS would really be perfect for more of a systems leadership role as well. Both, of course, but I do think that CNS is heavier in systems and NP could tend to be heavier in clinical. In the reading there, they do talk about the activities of a CNS are varied, right? There's a lot of diversity and differences in how people practice individually and how you are needed within your institution. Unlike other APRNs whose primary role is to deliver the direct patient care, the multifaceted CNS delivers direct patient care specifically to complex and vulnerable patients and populations while also educating and supporting staff and providing leadership within programs and systems. So it is a very unique a unique merging of all these traits kind of put in together. So I personally think it's really cool of how the CNS role works. They talked about the versatility of the role is really what typically attracts people to become a CNS. I would wonder for you students that are CNSs if that was something that drew you to decide between CNS or NP. But they also talked about the versatility of the role can also be a challenge of the role because maybe people don't clearly always understand how you are of benefit and what it is that a CNS could do. So clarifying the work and your core competencies of CNS, regardless of your specialty, has been complicated because the specialty organizations have historically been very varied. Your education has been varied. The definition of the competencies for many years was varied. And the practice standards for CNSs were not well established till about 1995. And so since that time, then things have definitely become more streamlined and more clearly articulated, which is wonderful. Your NACNS, in collaboration with the ANA and the American Association of College of Nurses, the AACN, have worked diligently to define your practice, your standards, and your competencies, and to really improve the curriculum at the graduate level. Very first part of your reading there, I did want to point out that they do specifically say that according to the consensus model for APRN, a defining factor for all APRNs is that a significant component of the education and practice be focused on the direct care of individuals. So if CNSs want to be recognized nationally or statewide as APRNs, they must have a component of direct care of individuals in the role. If the focus is primarily on educating nurses or just process improvement, and you really removed the direct care of individuals, then they would not fully be enacting the role of the CNS. So it's a unique combination then of specialty expertise, direct care, and the evidence-based practice, the quality improvement, and those subsets of skills that sets the CNS apart from other expert roles like a staff nurse, a nurse manager, or a QI specialist. And then they said, for the purpose of the clinical practice and licensure, accreditation, credentialing, and education, the work and contributions of CNSs as APRNs must be made unambiguously clear, which is really hard to do, right? All right, so you're going to be talking a lot as you get into CNS about your three spheres of influence with the interventions. So the three spheres of impact and Hamrick's 6 competencies will be used to organize and explain the CNS as they move forward throughout this chapter. So CNS students are encouraged to familiarize yourself with the Statement on Clinical Nurse Specialist Practice and Education, this NACNS from 2019, and with specialty-specific standards from the AACN. Regardless of setting, specialty, or population, the optimization of the CNS role involves the application of the 6 competencies across all 3 spheres of impact. Advanced practice competencies are categories of expected proficient performance and include specific knowledge in the skill sets. So the NACNS, along with all the other nursing organizations, have endorsed and defined entry-level competencies to be used by the graduate programs in CNSs within the 3 spheres of impact. So direct care of patients, nurses, and nursing practice, and the organizations and systems. And remember that the direct care of patients and families is the central competency in the Hamrick's model that we've talked about up until now, and therefore it links every other competency. So direct care of patients or clients involves obviously the direct actual hands-on care or the direct patient to CNS interface. Also involves collaboration and ethical decision-making and then acting as consultation. So in your reading, I would refer to table 12.1, the patient and direct care sphere. I love how they go through as the competency statement actually has 16 different characteristics of what this competency should look like as it applies to you as a CNS. And so, of course, it uses relationship building to promote health and wellness, etc., conducts a comprehensive health assessment, synthesizes assessment findings, designs evidence-based cost-effective interventions, implements customized evidence-based nursing interventions, and provides the direct care. You can prescribe medications, therapies, diagnostic studies, etc. The state of South Dakota has not yet given you prescriptive authority to my knowledge, but that's in the works. So CNSs, to my knowledge, in South Dakota cannot prescribe yet. Designs and employs educational strategies that consider readiness to learn, uses advanced communication skills in a complex situation and difficult conversations, provides expert consultation on a broad range of theories, provides education and coaching, evaluates impact of nursing interventions on patients' aggregates, leads and facilitates coordinated care and transitions, facilitates patient and family understanding, facilitates resolution of ethical conflicts, analyzes ethical impact, and advocates for patients' rights and preferences. When you get into nursing and nursing practice as a sphere, you'll provide expert specialty consultation to nurses, promote interventions that prevent the impact of implicit bias, advocate for nurses to practice to the full extent of their role, leads efforts to resolve ethical and moral distress, fosters a healthy work environment by exhibiting positive regard, employs conflict management and negotiation skills, assesses the nursing practice environment, uses evidence-based knowledge as a foundation for nursing practice, mentors nurses and nursing staff, leads nurses in the process of planning, implementing, and evaluating change, evaluates the outcome of nursing practice, facilitates opportunity for nurses, students, and other staff, engages nurses in reflective practice, mentors nurses, etc. So your nursing and nursing practice sphere has quite a few specifics listed in them. And again, coaching, guidance, consultation, collaboration, leadership, and EBP, the other competencies of the APRN are obviously interwoven into this sphere of influence for you. When they talked about organization systems, you're going to assess the needs of the organization, help develop research protocols, cultivate that culture, lead the improvement efforts, develop innovative models of care, develop and implement programs, participate in advisory boards, but you also provide leadership for the interprofessional team, partner with research, evaluate system-level interventions. You can demonstrate stewardship, etc. It's also really neat as far as the CNS role goes that I find fascinating, because I find it neat and fascinating, I should say, that you often will be executing several competencies at the same time. So you're serving as mentors, coaches, guides, counselors, all that stuff for nursing staff and other caregivers, while also providing direct patient care or acting within consultation. So that's pretty cool. You are supporting the nurses as well to promote ethical practice and mitigate the moral distress of nurses within a health environment. So, I mean, the way that these three spheres of influence intertwine is pretty neat. I think that the CNS brings a lot to the table and is a wonderful role. Throughout all the spheres, right, as a CNS, you're going to be also applying the steps of the nursing process, assessment, planning, implementation, and evaluation, right? But you're doing it now at an advanced expert level. Experienced CNSs understand that activities in each of these spheres of influence impact and integrate into your advanced practice competencies and are reciprocal, so that you'll have this synergistic effect moving between back and forth your APRN competencies, your spheres of influence, and you're doing simultaneous things at the same time, and they work very well together. The diversities of your activities and the challenges of the in the moment characterize a lot of what the CNS can do. Without sustained engagement, though, in that direct clinical care, it would be difficult, if not impossible, to be effective in the other two spheres, because the effectiveness of you as a CNS depends on your clinical credibility and your ability to evaluate practice at the patient interface. So I just love how they really integrate. Yes, you do direct care a lot, but that patient interface part has to also be there for you to function within your role. I also like in the book here that they talked about a CNS is most likely to care directly for a patient whose diagnosis or care is complex, unique, or problematic. CNS's care of specialty populations has resulted in improved patient outcomes and increased healthcare efficiencies. So high-risk patients with complex conditions have consistently shown improved patient outcomes and reduced healthcare costs when their care is influenced by a CNS and other APRNs directly. I love that. I'm sure you've read through your chapter of the CNS. It's phenomenal. I love it. It's worded very well. I like that they really go into the indirect practice in the reading and talk quite a bit about that. They mention the consultation as an expected skill of the CNS and often occurs within this indirect care realm. The indirect practice of CNS is also key in evaluating current and new technology, which is awesome because obviously we are in a technological era. I like the section also for you guys when you talked about the guidance and coaching within your reading. One of the essential components of the CNS role is that of the expert coach. And again, if you remember in my previous lectures, the differences between guidance, which is advising, and coaching, which is coaching. The role of guide or coach is used during teaching and mentoring to facilitate transition when a patient's in one situation to another, but you're also promoting professional and personal growth within the staff around you. So CNS uses formal and informal coaching and guidance with patients, families, nurses, other students, and other CNSs and the other health professionals. They really hit on the CNS and how you guys can have a direct impact with patient and families as a coach to emphasize the patient's accountability in their own healthcare. So it means that in addition to acting as a coach to individuals, the CNS is even more likely to be involved in like the education program plannings and interventions for groups of people. So that's pretty cool. Many patients know that they need to be better informed about their health and their risks. And a CNS must determine, when the patient's ready or what kind of coaching that they would benefit from. So I see guidance and coaching in the CNS realm for sure. And I don't think we can ever underscore the guidance and coaching that the CNS role does as well, actively every day with the nurses and other nursing staff. Oh, I skipped ahead too soon. I'm sorry. And as far as leadership goes, it is the very, skills that leadership or the very leadership skills that CNSs have that are often pulled away by administrators to lead other initiatives because CNSs do a great job with leading change and quality improvement and performance improvement projects. So a CNS has responsibility for clinical innovation and change within a patient care system to improve outcomes. And so the leadership is also very key. And just like the other APRN components, through leadership, it is the gateway for you to enact your spheres of influence and all of your other APRN competencies like leadership, coaching, mentoring, guidance, and those things. Collaboration, I would argue, is even more pronounced or more important, but that's not the word I quite want to say for the CNS versus the NP, because you, as a CNS, are going to be regularly interacting with a wide variety of people. You will be touching base with all members of all the teams. So everybody that has an impact on that environment within your work, you could possibly be collaborating with. So that's other patients, families, doctors, nurses, therapy, pharmacy, environmental services, or housekeeping. All of those people are people that you would likely touch base with to help coordinate or improve the care of whatever you're working on, because all of those pieces affect the environment. The example that they gave was the future of nursing leading change. Talked about that you could possibly be talking to people in the supply chain, finance, security, operations, within the other departments of the facility. And so that's really cool. That's really where the CNS role shines in collaboration, is what I would say. And being a CNS, you'll be able to integrate many individuals and what they are bringing to the table with their different perspectives, and help integrate everybody, and let everybody have a seat at the table and help facilitate that interaction as part of your collaboration competency. You're going to be excellent at communication to help foster trust and growth in collaboration. That's really, I would argue, communication then is the heart of collaboration. You have to be skilled in helping all the team members address and negotiate conflicts so that we can still reach our optimal patient care goal. They did talk about the blurring of the boundaries between healthcare professionals can occur as the CNS role develops. So there can be overlap between the CNS and the staff nurse, between the CNS and the physician, or between the CNS and other APRNs. And it's important that communication is key again, because it's important that clear communication can occur, because without that collaborators, their lines will be blurred, and that's when negative emotions and things that can happen, and that can result in gaps or duplication of care or unclear accountability. And so as a CNS, you're going to be able to navigate all of these different arenas and all of the people's views and attitudes and beliefs well, because you're going to be skilled in good communication and collaboration. So that's pretty awesome. New opportunities for the expanded CNS practice. Again, at the national level, and the Affordable Care Act did help expand and recognize the CNS, and kind of opened doors for the CNS to be recognized. Successful CNSs have consistently delivered direct and indirect care. Again, we say that can improve patient quality and outcomes. We improve patient safety and nursing practice. We're efficient at using resources, cost saving, and revenue generation. And that's beginning to be recognized at bigger, higher levels. The direct clinical practice slide here. Competency of direct clinical practice is linked to the patient spheres of influence, like we've talked about. The advanced assessment skills and integration of biophysical, psychosocial, behavioral, sociopolitical, cultural, economic, and nursing science statement not found in textbook or cited, but I do think is very poignant to point out. The activities and responsibilities that occur within the patient-nurse interface will be something you do in direct clinical practice, and this will afford you the opportunity to assess quality of care for that population that you're working with. I know I kind of jumped around in my slides, sorry, but again, the guidance and coaching can be formal or informal, and it's wonderful because you have a specialty will definitely be working with patients, but also families, nurses, everybody that interacts at any level with patient care. I like that they define internal consultation and external consultation. So you can assist staff in facilitating development in their own practice, or you can be more into the external environment. Your evidence-based practice involvement in evaluation and improvement of nursing practices ranges from your scholarly inquiry to formal scientific investigation. Collaboration between the PhD nursing faculty and CNS, where CNS lends clinical expertise to research component and supports evidence-based practice in your practice setting. And the CNS can use research to influence public policy. Leadership is integral. Again, we reviewed that already. I love this part here. The CNS role is already recognized by hospitals seeking to obtain and maintain their magnet status. So it's almost impossible for a hospital system to maintain their magnet status without CNSs because of your ability to integrate all of the different things that affect direct patient care well. We already went through this one with the collaboration. Sorry, I didn't keep up with my own slides. I got to talking. Effective nursing care is maximized and outcomes are improved when CNSs are included in the interprofessional ethical decision-making, again, because you see those spheres of influence and how they intertwine and bring all of that view to the table is a wonderful thing that the CNS can do. When we talk about your scope of practice and delegated authority, it's really important, and again, you're going to talk about this more when you're in with Lynn, but for your knowledge, your scope of practice is determined by your state board of nursing. So we have at the national level, you will have organizations like your NACNS advocating and defining what the CNS role is and driving with the curriculum at the graduate level and all of those things. So you have that national advocacy for the CNS. But ultimately, it's up to each state to to define your scope of practice. So what a CNS scope of practice can be in South Dakota may be different than in Montana, may be different in Florida. So that is something that you are obligated to know wherever you're practicing that you ultimately are within your scope of practice. It's important to understand that facilities, then, the institution you work in within your state, also can have their definition of what your role looks like. So within your job description and how they are hiring you to the role and how they're defining that role that you choose to come into may have other definitions of how you're going to practice and may have things that restrict your practice or maybe don't allow you to practice to the full extent. So even if the State Board of Nursing says you can do A, B, and C, if you take a job within an institution that says we at an institutional level do not allow you to do that, you are stuck there, right? So they cannot, you can't just say, well, the state says I can, so therefore I'm going to. That's not the way that works. But also, though, if the institution that you're working with wants you to practice outside of your state's scope, you cannot do that. You are then held by, you can't go above and beyond the state's definition of your practice. In 2020, the National Council of State Boards of Nursing did adopt the APRN Compact. And through the APRN Compact, an APRN would hold a multi-state license that would allow them to practice in any state that has enacted the compact legislation. So right now, it just recently in 2024 has gone up to 4 states. So North Dakota was the first, South Dakota just passed it, and they have to get to 7 states before that it can go into practice. So South Dakota is supporting it and have endorsed it and approved it, but it's still not a possibility yet until 7 states join. So that's really cool, and hopefully one day we will see that as which means that, you could go to North Dakota and not need multi-state licensing to practice. It is kind of neat that the VA, the Veterans Health Administration, to standardize the CNS practice despite state differences, a ruling by the VA allows a CNS to work to their full practice authority within the VA facilities and not within the individual state's scope of practice, which is kind of cool. All health professions have an autonomy within their domain of practice as well as delegated authority within the medical domain. So what does that mean? As a consequence, other health professionals and CNSs, we've had to kind of carve out what we do. And there are things that you will do as an APRN CNS that used to be only in the purview of physicians that now we can do. Like you've been training on how to do, or you will be training on how to do procedures, etc. For CNSs specifically, the delegated authority from the medical arena or from your institution continues to pose an issue as you try to be independent in your scope of practice. Practice restrictions at the national level, they advocate that they need to be removed so that the CNS can practice to the full extent of your education to meet the needs of the patient. But this is something that's still a work in progress, and you may certainly find yourself being in a position to advocate for the APRN and for the CNS role all the way around. The chapter also went into the Institute of Medicine, The Future of Nursing report from 2011, and they stated that there were 4 key messages and 8 recommendations as the blueprint for change in nursing and advanced practice nursing to meet the needs. And the most specific key messages for CNSs is supporting all APRNs being able to practice to the full extent of their education and training. Nurses should achieve higher levels of education and training through improved education systems that promote seamless academic progression. Nurses should be full partners with physicians and other professionals in redesigning healthcare in the U.S., and effective workforce planning and policy making require better data collection and improved information infrastructure. And these are listed then in Table 12.2. Specifically, when they talk about when they talked about the message 1, the book talks about that there should be eliminating any requirements for physicians in their collaborative practice agreements, removing prescribing limitations, amend requirements for hospital participation in the Medicare program to ensure that CNSs are eligible for privileging, admitting privileging, and membership on medical staffs. If you are not familiar with that yet, you're going to talk a lot more about that in the future, but a quick definition of this. So when you go to practice within a healthcare system, a hospital, a clinic, whatever it is, you have to apply to have credentialing and privileges given to you. So when you apply for a job, they're going to get you credentialed. And to do that, they're going to verify your transcripts, your national licensure, your background check, all of those things as part of credentialing to verify you are who you say you are and you can do what you say you do. So when that's the process that you'll do for credentialing. And then you apply for privileges. So what are you allowed to do within the hospital setting? And that is where it can be sticky for APRNs in general and for you as a CNS. So if you complete your training with Augie, and at the end of it, you have been trained on how to do a central line and a chest tube, for example. When you come into practice at that institution, you can apply for the privileges to be granted the privilege to do those procedures, and you cannot do them without privileges. Like you'll be fired if you do something outside of your privileges. Oftentimes, depending on the institute for an APRN, they are very worded details. Sometimes they're 2 pages, sometimes they're 5, but it's literally the privileges to do admission orders, discharge summaries, H&Ps, whether or not you could be privileged to do death certificates, all these things. Whether or not you're allowed to put in an intraosseous, whether or not you're allowed to put in an IV line, whether or not you're allowed to do incision and drainage, local anesthetic, reduction of a joint, splinting, casting, suturing, all of those things will be listed out of what you're allowed to do. Those are kind of typically kind of clumped together, and then past that is typically then super specialized things. So if you're working in oncology, are you asking for privileges to be able to do bone marrow biopsy and aspiration? Are you working with cardiology and you're trying to be allowed to do cardiac stress tests? Are you allowed to interpret 12-lead EKGs? Are you allowed to all of the different things and procedures that you're allowed to do? If you're in orthopedics, are you allowed to aspirate a joint or inject a joint, etc.? So all of those things are credentialed and procedures or privilege. So your job can literally say to you yes or no. So they can say, we don't do that here. CNSs don't get that privilege. And you can fight them for that, and advocate for yourself. But if they, at the end of the day, say, no, you aren't allowed to do that in our facility, even if the Board of Nursing says, yes, she can, if they say, no, she can't, you're stuck with that, right? So those are the things that affect your ability. So what they're talking about is that they are advocating for, we need to allow people like a CNS or an APRN to practice to the full extent of their training, because then they're meeting the needs of our patients and they're bringing more to the table. But that's kind of a quick understanding of what it means to have that. So what they're also saying then is that amend your requirements for hospital participation is that Medicare will recognize you as a CNS to write, for example, admission orders to the unit. But if your facility doesn't allow you to do that, it doesn't matter that CMS would pay you for that, right? You're kind of stuck there. Then this next one, nurses should achieve their higher levels of education and training. The example in the book is that you could work at advocating for a CNS focused courses in a doctoral program. advocate for seamless progression to DNP for CNSs. There's a lot of that there. For number 3, nurses should be full partners. So you as a CNS definitely would be promoting and supporting an environment for the nurses and for the CNSs to be actively involved in the change and redesigning and changing the landscape of healthcare in America, literally. And then the last one, effective workforce planning and policy making includes recommendations by CNSs when you're trying to work at national level or policy level. And there's definitely room where the CNS is going to shine and make a big impact there. Consensus model for APRN regulations and what that means for the CNS. Models delineate the scope of practice for APRNs and defines the regulation in licensure, accreditation, certification, and education program requirements. This is referred to as LACE, L-A-C-E. And so the consensus model defined that. So the purpose of that, again, was to delineate the scope of practice for APRNs and define the regulation of APRNs in the areas of the LACE. The CNS role, it's important to note that the regulatory APRN model does not encompass a full conceptual understanding of advanced practice nursing. So there's some debate and argument within the nursing arena regarding the CNS role and whether or not it should be lumped in with other APRN roles. And that sometimes comes from the contention to the differences between a regulatory and a conceptual approach to the CNS. But title, protection, and scopes of practice for CNSs are highly variable from state to state, and the consensus model clarifies that the CNS is one of the 4 APRN roles and that all APRNs have a patient-focused practice and should then have the legal authority to perform acts of advanced assessment, diagnosing, prescribing, and ordering. But currently, there are some states where CNSs are not under authorization by the Board of Nursing, but under the Department of Health, which is a huge deal, and they're trying desperately to get back under the Department of Nursing. So CNSs must incorporate a component of direct care into their practice to reclaim and maintain the regulatory and professional recognition that CNSs are, in fact, APRNs. The consensus model requires title protection for CNSs, which would be a step forward for those states that do not have the basic regulatory requirement. A grandfather clause, which would mean recognizing and granting authority to APRNs who are titled that way, who graduated from accredited programs and were in practice before the implementation of the consensus model, is included. And the grandfather clause is very important for CNSs because the certification exams are not available for all population focuses. And population focus levels is required for all APRNs to be licensed at the advanced practice level. So CNS certification in a specialty like oncology is voluntary and is outside the licensure of an APRN once an individual state fully adopts the consensus model. I talked a little bit in your reading too. At the 2018 NCSBN meeting, it was recognized that the APRN consensus model was 10 years old already, and there were inconsistencies in both the regulatory interpretation and the implementation of the model in states. So resolutions were passed that included convening a forum of state board regulators to examine those issues, and a report was delivered in 2019 at the annual meeting. And although issues were discussed were of more relevance to NPs and CRNAs, the implication of implementing those decisions would impact CNSs as well. The example they gave is NPs wanting to be called NPs as opposed to APRNs, and the CRNA's preference to be called a nurse anesthesiologist. Changing the APRN title would minimally have an impact on CNS billing, but the final recommendation of the discussion was that the consensus model should not be revised. So reimbursement for you as a CNS. In 2019, then President Trump signed the executive order with the goal of enabling providers to spend more time with their patients. It directed the Secretary of Health and Human Services to reform the Medicare program to eliminate excessive supervision requirements for the APRN. It mandated to provide equal pay for equal work of the physician and remove unspecified conditions of participation requirements and operationalize the CNS practice that they're allowed to practice to the full extent of your education. If enacted, the unspecified supervision requirements and conditions of participation and the license requirements that do not allow clinicians to work at the top of their profession would be eliminated. So in addition, pay disparities would be eliminated and that the APRN would be no longer reimbursed at only 85% of the physician. So if you're not familiar with that, what happens is that if the care is provided by an APRN versus a physician, the physicians receive the 100%. So if it's worth $1,000, the physician would receive $1,000. If the same care is delivered by you as a CNS, you would get paid $850. You'd get 85%. So that executive order was the goal to tell CMS you can no longer do that. But in 2019, a report to Congress, it was identified that APRNs and physicians' assistants were actually providing an increasing share of medical services. And they also recommended changes specific to this Incident to billing, so changes were made. So APRNs, including you as a CNS, can bill under Incident to category. This allows the APRN to be reimbursed at 100% if the services provided meet certain criteria, including the services billed under the NPI of a supervising physician. However, if you want to again bill under yourself, you only get 85%. The committee recommended that Congress eliminate the Incident to billing and that the Secretary of HHS refine Medicare's designation for APRNs. So there's still a lot of work out there. And this will be something that you will negotiate or figure out how your facility wants you to do that. I can tell you in my practice, think about this a second. If it's a difference of, $150, for example, let's say that example of the physician, you could bill $1,000 and you could bill $850. Well, if you bill Incident to, meaning you bill under the physician because you discussed it with them, you collaborate with them, et cetera, and they get that $1,000. Well, some people would argue, hey, it's only $150. But imagine $150 across 1,000 patients. I mean, that's a lot of money to be left at the table. So when we come to the table as APRNs and say we want to bill independently, be recognized for our own work, you can kind of see how health institutions like, hey, that's all good, but until Medicare changes it, we're doing it this way because we need the money, right? So we have a steep hill to climb when we have that barrier, because nobody is going to be like, oh, sure, it's just $150. They're like, hey, it's money left on the table. If we have a way to do it to get more money, we're going to do that. So that definitely can be a barrier for the APRN to be able to be practicing at their full extent. The other trouble with that is that when we go to monitor our outcomes as APRNs, in order to do that, to monitor outcomes, we have to be able to retrieve data. You have to be able to tease out what the APRN is actually doing. And one of the ways, and one of the only ways really that's efficient to do that, is by going into the data and mining for billing and coding. So you would type in my name, Sarah Becker, and these codes and see how many of those I did and what the outcomes were for those patients, et cetera. But if I'm billing Incident to and under the physician, it becomes really difficult to tease out what work I am doing. And then it becomes difficult for us to monitor our outcomes and then be able to use that data to help advocate for ourselves. So it's not just about us personally being recognized for the work we do. It's also for us as a whole that this gets a really messy area and really difficult. It does limit us when we're talking more macro level of how the APRN can function. For the CNS role especially, there's been a lot of push to really make sure that your education curriculum is geared towards the CNS. So there's a lot of variabilities in the programs that are out there, including the expectations for students, how they are evaluated, etc. Again, because you as a CNS, you still fall under an APRN, you have to have the 3 Ps. And then the AACN recommends use of simulation to enhance clinical experience, academic practice partnerships, competency-based addition and assessments, etc. When you get into your next semester and we start doing your immersions, you are going to be jumping right into this clinical experience and a lot of simulation, which is really neat. However, it is difficult for the CNS still because of this disparity between state to state variations and how you are defined and recognized. So when we talk about how a program is designing your curriculum, that is challenging if there's such a variation across state to state to state to have a standardized approach across the country because there's so much variation there. So that is a toughie as well. Slide here talks about the national certification for CNSs. Certification at your population level is available through the ANCC and the American Association of Critical Care Nurses. You can go on to have specialty CNS certifications for something such as oncology. The certifications aren't available for many of the specialties, but I do think that's something in the next 20 years, kind of time will continue to change, hopefully. Prescriptive authority is also a major barrier sometimes as well. Skipping ahead here, oops, 1 second, let me get my slides. Variability and this, the prescriptive authority we kind of talked about. As of 2010, there's 22 states that allow the CNS to prescribe independently. All right, the differences between a CNS and an NP. The first CNS educational program developed in response to the needs for nurses with this specialized knowledge in psychiatric nursing. That's kind of historically where that came from. There are differences between the two roles. Significantly, the amount of time spent performing a particular competency or activity is different for each. For example, the adult gerontological acute and critical care CNS spends time among your 3 spheres of impact as outlined by the NACNS, whereas the AGCNP, the acute care NP, spends most of their time in direct care management of patients. In the systemic review of the global literature in 2019, they examined the similarities and differences between CNSs and NPs. They found that both the roles had improved the quality of patient care and provided a similar quality of care as physicians. Both were cost-effective and both reduced waiting times and waiting lists for patients to be seen and had an almost equal positive impact. The differences between the NPs and CNS were defined that NPs were more generalist and the CNSs were more specialists. In 2018, when they reviewed this as well, they examined the similarities and differences between the two roles and found that although the educational preparation is many times seen as very similar, in reality they are two distinct roles and the scope of the CNS is distinguishable from that of the other APRNs. With the introduction now of the DNP, the Doctorate of Nursing Practice degree, core competencies for APRNs who graduate from these programs will have a balance of direct care management education and didactic instruction in education and systems changes to produce a more well-rounded clinician. So CNSs receive more instruction about direct care management in the DNP, and the NPs receive more instruction about education and EBP evaluation and implementation than prior to being a DNP. I can tell you, me personally, from my experience, that was very much the case. When I went back for my DNP, I felt like I really expanded my world of knowledge into more of what a CNS is, looking at systems, leadership, a more macro level, how to support nurses. So I do feel like having the DNP as a nurse practitioner has made me function a lot more similarly at times like a CNS. So I think that's what they're saying here is that as CNSs and NPs go into the DNP realm, they may have a lot more merging of similarities. Although the two roles are receiving similar education content and have some overlap in skills, it still remains unclear whether this shift of the DNP education will substantially change their daily patterns or not. They did talk a little bit here about repurposing CNSs into quality managers, case managers, nurse education, and educators has decreased the number of nurses entering CNS programs, which is a great shame to me. There's very much a need for both. You need a nurse manager, but you also need CNSs. They talk about the first NP role developed in pediatrics to help relieve shortage of physicians in the poor rural and urban areas. And NPs began diagnosing, treating, providing primary care. And today, NPs are entering specialty practice because of the need for specialists has grown. And again, as NPs, we spend most of our time in direct care of the patient. The role implementation is challenging because, again, for a lot of states and facilities, there still is this lack of clarity of what a CNS can do. So it's imperative that as a CNS entering a new position, that you understand and prepare for the optimal entry into that role. Organizational structural factors identified by the CNSs included making certain that orientation is planned and structured rather than having an ad hoc approach with each new CNS, ensuring adequate leadership support and stakeholder involvement, and having a structure that facilitates team support. CNSs should take personal accountability to obtain certification in specialty area of practice, which helps your clinical visibility as well as your validity and reliability within practice. Process factors that the CNSs have identified that were really important to successful role implementation included consistent role titles and expectations, because that can help facilitate your interprofessional and interprofessional relationship development. And be clear with how you fall into the reporting structure and function within your facility. Are you reporting to physicians? Are you reporting to the chief nursing officer? How does this look? And again, both have advantages and disadvantages. Understanding the reporting structure and corresponding implications is important for any new CNS to the role because they may result in barriers in you being able to practice at your full extent. You have to pay attention to things like what your expectation is, how much time you're expected, so on and so forth. Evaluation of practice. CNSs should consider how to evaluate, track, and demonstrate outcomes from day one, because the full extent of your impact and outcomes may not always be readily visible. And it's important then that you are from day one in your new role anticipating how you're going to justify your work and show your work in tracking and demonstrating your outcomes. Although many CNS specialties develop practice setting specific evaluation tools, a standardized tool should be developed for expected competencies and the assurance of outcome quality. Portfolios can be used as a tool to help show your practice and track your outcomes. Some CNSs document the components of their clinical practice, such as the number of patients seen, types and frequency of intervention, outcomes achieved, educational activities for the staff, system initiatives, etc. And this is also important because we've struggled historically as an APRN community to really show the impact of CNSs because we haven't been tracking data and outcomes yet. And that is changing slowly but surely, but this is where this is coming from, that we need to be able to say, look, this is the work I do and how I'm making an impact. All right, and future directions for CNSs. 3 powerful forces will influence your practice and your regulation of the APRN. One was the IOM of 2011 that we talked about. The other one is any updates to the consensus model for APRN regulation, and the other one then is healthcare reform. Undoubtedly, additional forces are impacting and will continue to impact CNS practice. The COVID-19 pandemic has changed the landscape of practice and probably has changed the outscape of the CNS role. There's lots of ideas out there of ways and opportunities for the CNSs to advance their role, but at the same time, the CNS role is threatened by wide variability in the philosophy, education, and operationalization that perpetuates role confusion and ambiguity among those in the CNS community and employers. So they talked about the 5 sections for survival of the CNS role. I love these. One is the cohesive voice. So there's a need to unify around the SBN regulatory affirmation of CNSs as being APRN, so the Board of Nursing. To have a cohesive voice, the CNSs need to unify with a significant component of practice of direct care of individuals in their expanded scope of practice. That includes advanced assessment, diagnosing, prescribing, and ordering. This cohesive voice must advocate for all activities to be legally permissible in state scopes of practice and in individual practice, regardless of individual preferences. The use of the common language shared by all APRN groups is essential for identifying shared knowledge, skills, and practices, and that helps reduce the perception of infighting and can advance the CNS as an APRN role. There's strength in numbers, okay? Then you must clearly articulate their contributions to patients, families, and the healthcare system in their 3 spheres of influence, right? CNSs, by claiming the definition of CNS practice, CNSs, then you guys can differentiate yourself from the other APRNs and can still argue how you provide direct and indirect care and you are improving health outcomes of patients. Must ensure that educational programs and continuing educational programs have appropriate preparation and content. Adherence to the AACN Essentials is mandatory for the accreditation of APRN programs and serves as the basis for educational standards. Preceptors must have your CNS students engage in activities in these 3 spheres of CNS practice to prepare them for a future successful practice. Continuing education programs for CNSs should increase the course offerings to include care management of the specialty populations and really make sure that we are providing access to education for CNSs in addition to all of the other APRN roles. They need to be, CNSs need to be involved with partnering with others to enact role opportunities related to healthcare reform. One of the areas is research. A CNS needs to be innovative in partnering with others to reform healthcare. CNS models of populations should be developed and researched. Those can include things beyond the traditional inpatient CNS role. CNSs should collaborate with nurse researchers in conducting and publishing comparative effectiveness studies that test the efficacy of the CNS interventions in these complex and vulnerable patient populations to show improved patient outcomes and innovative new care models. CNSs continue to need to establish that patient outcomes are improved, safe, and are still as of high quality as a direct result of your role and your interventions compared with out you being around, right? You have to continue to justify and to show the work that you bring and how you bring that to the table. More studies need to be carried out to compare CNS effectiveness in achieving the patient outcomes as compared to other APRNs as well. And then there's a need to seek recognition locally, state, and nationally, and even internationally through involvement in policy making and healthcare reforms. Local recognition can be obtained by seeking institutional credentialing and privileging and ensuring that your job description at your institution or your place of employment incorporates the 3 spheres of impact with particular attention to the direct care of individuals. CNSs must become involved in passing regulations and legislation using the consensus model language that includes CNSs as APRNs and your state boards of nursing. CNSs should lobby and advocate for national certification mechanisms that accurately reflect your CNS practice. CNSs need to monitor national change to regulation in agencies like Medicare and Medicaid to ensure that the CNS contribution continues to be recognized and reimbursed appropriately. So, CNSs uniquely are prepared to provide this advanced practice and specialist expertise with complex and vulnerable patients, education and support of interprofessional staff, and change and innovation in healthcare systems. As healthcare reform continues to gain momentum, there's going to be lots of opportunities for CNSs. And really, I agree, the possibilities are endless. So again, as a CNS, you're going to demonstrate your 6 competencies of APRN practice through your 3 spheres of impact, which are the direct patient care, nurses and nursing practice sphere, and systems and organization sphere. And that's going to be regardless of where you practice, inpatient, outpatient, whatever the setting or specialty. And be prepared to be persistent and unified in being able to clearly articulate your unique contribution to the role within your institution. You're going to play a role to patients, families, and others, and be able to clearly articulate and advocate for yourself, and anticipate that you're going to be stepping into innovative efforts and ways to show that you guys as CNSs, your work that is brought to the table is valuable. You're improving outcomes, patient safety, etc. I think the role of the CNS is an awesome one. I think that there's going to be just this big boom for it now that it's able to be better recognized and reimbursed. And I love the idea of what CNSs and nurse practitioners can bring to the table when they're working together or alongside each other within the same healthcare system. So this is that. You stuck with me an hour. This is kind of a quick dive into the CNS realm. Again, most of this is going to be all of this is going to be discussed in depth over here next year as you move into your CNS specific courses. So please, as always, let me know if you have any questions, thoughts, concerns, and talk soon.